Well, hello again, folks. We're going to go ahead and do a storm pack today. This is a brief voiceover PowerPoint on some of the parts of the lesson that I wanted to be sure to review with you before you got into your lesson activities. So there is a set of posted instructions. Your pretest is already open and it is due Tuesday at midnight. There is this voiceover PowerPoint to view. There are two acute renal failure videos that I've posted. They are new. They're different than the ones on the reading list. I think they're better. Thank you for understanding. I wanted to give you just a little more meat to chew on. And then you're going to go ahead and participate in the student presentation discussion. And your post is due by Wednesday midnight. And then you'll participate in an unfolding GI case discussion board, and that's all explained there. You have two posts due, one Wednesday and one Friday. So we have, of course, objectives for our lesson, which really focus around lab interpretation, clinical reasoning, and comprehensive plans of care. These are our topics. We'll focus mostly on the renal disorders this time, and we will look just at the one case in GI, and next time we'll get more depth into the GI. I wanted to just touch base briefly and just a little bit of mention about the pyelonephritis. Of course, we have an excellent student presentation about UTI, and those folks did a very nice job bringing pyelonephritis into the picture. I wanted to just post this as a kind of cartoon representation of what we anticipate and expect when the infections travel uphill, if you will, from the lower urinary tract to the upper urinary tract. And you can well imagine that this kind of progression of infection is more prominent in certain populations. I'm particularly always worried about my very young patients, infants and small children. I worry about my elders who have blunted responses and blunted fever, blunted kind of specific response. It's kind of very similar to children. So they have a more generalized response and have a lot of the altered mental status, which is something that was mentioned in the student presentation as well. I always also worry about pregnant women and people with diabetes. And for pregnant women, it has to do with kind of the anatomical shift with the pressure of the pregnant uterus upon the structures of the urinary tract, causing kind of physiologic obstruction and thus sometimes problems with increased tendency towards urinary tract infections. And with our folks with diabetes, like our elders and very young, they have a suppressed immune system. And so I'm always concerned that they may develop pyelo. In addition, people who, for whatever reason, either it can be because the way that their body responds to the infection of the lower urinary tract, that they don't really sense that they have a bad infection. They may be obstructed with substances. It just may be the way that they are. Some people will tell you that they never really know that they have a urinary tract infection. Or in the case of one of my most memorable cases in my practice, my very first patient at my free clinic, she put off care for her urinary tract infection, her lower urinary tract infection, because she did not want to incur a bill at the emergency room. Our free clinic opened. She was our very first patient, and she, by the time I saw her, had pyelonephritis, although not severe enough to hospitalize her. She was fairly young and healthy. We were able to treat her as an outpatient. And so many causes for the infection kind of getting out of control. Always want to be cautious about that and not dismiss UTIs as not important. I wanted to take you out to a little video here that I thought would be important to reconfirm our skills in terms of checking for costovertebral angle tenderness, or CVAT.
This slide depicts the fist percussion test over the kidney at the costovertebral angle for kidney disorders. A positive finding on this test would be pain with a firm thump of the fisted hand. If you suspect that there could be a kidney disorder mimicking musculoskeletal pain, the fist percussion test can be utilized. You palpate the costovertebral angle at the 12th rib, place your non-dominant hand over the costovertebral angle, and testing the left kidney, you produce one firm thud over that area. To test the right, palpate the right costovertebral angle, move the hand over that area, and again, a firm thud. This should be painless, though the patients will feel the pressure of that force. If there is a kidney disorder, patients will often report pain.
So this is just another picture of the same concept. Looking at labs, I want to dig into that a little bit in the urinalysis, and I know in the student presentation we talk a lot about this. But one of the things that I find helpful is to kind of dig in a little deeper, and one of the great articles that is helpful is this one from the Medscape series. And I'm going to take you to that with some highlighted sections that I have set aside for myself for my own reference. So I'm scrolling down through this document, and I'm just going to comment on a few of the little areas that I highlighted for my own reference. First of all, of course, we know that looking at urine color can sometimes give us some clues about what's going on in the urine and in the kidneys. However, generally we think of concentrated urine as being darker, and volume depletion being kind of a common cause. However, there are some colorings that can occur mediated by foods and medications, as well as various conditions. And there's all colors of the rainbow here involved. And so it's important to think about that, and patients may report some unusual colors to you. There are various substances in the urine that can make it cloudy or not clear. And so that is something noted by the examiners when you send a urine specimen to lab. Of course, the first thing you'll see reported as well is the urine pH, and of course the excretion of the hydrogen ion really is one of the ways that our body's acid-base balance is regulated, is by the urine excretion of that hydrogen ion. There are things that can affect the pH levels, and we like to see a more acidic urine for people who have frequent urinary tract infections. That does seem to help. And so cranberries and high protein foods. Of course, the pH may help us distinguish around various renal calculi, which is something we might take a look at. Specific gravity is one of my favorites. It is often reflective of hydration status. However, there are some things that may alter that, especially in terms of glucose, urea, or urate, and protein or keto acids. So it's just important that even though it's a pretty good indicator, again, high specific gravity, saying they're a little more dehydrated or dry, and low specific gravity, they're hydrated well, or maybe overhydrated, or may even have something like diabetes insipidus. Glucose, of course, shows up only with very high levels of glucose in the blood. Ketones, pretty usually considered abnormal, but we can see situations where severe exercise, vomiting, and pregnancy, starvation can cause some ketones in the urine. So I've seen it in vomiting quite a bit myself in urgent care environments, and you always want to recheck it after the fact. We talk about nitrates being a really important indicator of potential infection. They kind of tell us, yep, if they're positive, we probably do have an infection. It's probably E. coli, although there are others. However, if we don't have a positive, it doesn't mean they don't. WBCs, of course, leukocytosis, leukes in the urine is definitely a sign of infection, although it can be contaminant as well. Proteins are something important to think about in urine, and we can see it on the dipstick really when the urine proteins are pretty high. So microalbuminuria has to be tested by different tests. There are special tests. You can send a spot microalbumin test off if there is a concern about with diabetes, but we'll talk about that more next semester. And of course, proteinuria, you can have a falsely elevated protein on the dipstick because of urine concentration. You really need, if you see protein in the urine, you really need a 24-hour urine collection to confirm that. Again, however, we might have transient proteinuria because, again, proteinuria is telling us there's damage possibly to the kidneys, and we're really concerned about it. But we can see it with fever and stress and even strenuous exercise. So there are some things that we're going to see spilling protein that don't worry us. Persistent, of course, would worry us. I'm going to scan through the RBCs in the urine. Again, there may be various causes for a positive dipstick. It's really very sensitive. It's only 3 RBCs have to be present, and so that is a very sensitive versus protein being insensitive test on the dipstick, and you have to confirm with microscopic to figure out what's going on, and it needs to be followed very carefully. Again, another topic for some chronic discussion. WBCs, this is per high-powered field. This is microscopic exam, which is not something most of us do in office. You're going to send that out to a lab. This is just a repeat of telling us that on our lab slip, we're going to see that if they have less than 5 WBCs per high-powered field, we're probably not going to think it's an infection. What else did I want to talk about? Oh, casts. Casts are something that we worry about. Sometimes we see normal hyaline casts, but red cell casts are something we do worry about and think that they may have some glomerulonephritis. And this is just more discussion about the hematuria. I'm going to leave that here for now, and there's a part 2 to this voiceover PowerPoint for you. Thanks.